Obesity. It is due to excess of adipose tissue deposition. It is seen in more than 20% of children in urban India. Energy intake is more than expenditure. Increased deposition of adipose primarily in the abdomen. Central obesity is more increased risk of complication. Note, body has unlimited capacity for storage of fat but not carbohydrates or proteins. Definition. So, body mass index used for children more than 5-year old. BMI is equal to weight in kg upon height in meter square into 100. It is plotted in BMI charts. Overweight is more than 23 in adult and obesity is more than 27 adult equivalent. And overweight is more than 23 adult equivalent. Weight for height. For children less than 5 years, you go for weight for height, not BMI. For less than 5 years children, you go for weight for height and not BMI. WHO weight for height chart is used. Plus 2 to plus 3 ST is overweight. More than plus 3 ST is obesity. So more than plus 3 ST is obesity. Skin fold thickness and subcutaneous fat. It is measured by Harpenden caliper. It should be more than 85th percentile is obesity. Skin fold thickness and due to increased subcutaneous fat, measured by Harpenden caliper, and it should be more than 85th percentile obesity. Waist circumference indicator of abdominal obesity. More than 75th percentile, more than 80 centimeter in girls and more than 90 centimeter in boys. Waist hip ratio age independent. Ratio of waist circumference to hip circumference. More than 1 in males and more than 0.85 in females is obesity. Waist to hip ratio. If it is more than 1 in males and more than 0.585 in females. Waist to height ratio. Age independent. Waist to hip ratio is age independent and waist to height ratio is also age independent. Should be more than 0.5 to be called obesity. BMI interpretation is based on Indian Association of Pediatrics BMI chart. Etiology: obesity. Constitutional, exogenous, most common cause of obesity. So obesity can be constitutional, exogenous, that is most common. Causes is excess food intake, inadequate exercise. Characteristic: child has tall stature due to increased insulin and increased insulin-like growth factor. Generalized obesity. Pathological: usually child is of short stature. So in constitutional, you will see that child is tall, but in pathological, you'll see that child is short. Causes of pathological obesity, monogenic causes, hereditary single gene defect, positive family history. Mineralocorticoid 4 receptor defect, MCAR, that is most common. What are the causes of pathological obesity? Monogenic causes, single gene defect. So that is hereditarily single gene defects, positive family history. Mineralocorticoid 4 receptor defect, MCAR, most common. Mineralocorticoid 4 receptor defect, MCAR. Leptin deficiency, decreased leptin resistance to leptin. Uncontrolled appetite, leptin deficiency, that is decreased leptin and resistance to leptin will cause uncontrolled appetite. Leptin deficiency was the first reported monogenic cause of obesity. Endocrine causes, Cushing syndrome, truncal obesity, buffalo hump, stria, moon phase. You have your hypothyroidism, pseudohypoparathyroidism, growth hormone deficiency, hypothalamic obesity, lesion in ventromedial nucleus, satiety center, uncontrolled appetite, lesion in ventromedial nucleus, VMN, satiety center, uncontrolled appetite. Causes happens in head injury, tumor, radiation, and infection. Rohat is the mnemonic, and that is because hypothalamic obesity is rapid onset obesity with hypothalamic dysfunction. H, hypoventilation, autonomic dysregulation. Causes of hypothalamic obesity is head injury, tumor, radiation, and infection. Hypothalamic dysfunction. Coming next to the next reason is syndromic obesity. Prader-Willi syndrome, genetic imprinting disorder. Clinical features: hypogonadism, small hands and feet, almond-shaped eyes. That is your Prader-Willi syndrome, genetic imprinting disorder. Clinical features are hypogonadism, small hands and feet, almond-shaped eyes. Beckwith-Wiedemann syndrome. Clinical features: obesity, macroglossia, organomegaly, hemihypertrophy. Beckwith-Wiedemann syndrome. Clinical features: obesity, macroglossia, organomegaly, and hemihypertrophy. Beckwith-Wiedemann syndrome. Clinical feature: obesity, macroglossia, organomegaly, and hemihypertrophy. Lawrence-Moon, LM, and Biedl-Bardet syndrome. Clinical features: Lawrence-Moon and Biedl-Bardet syndrome. What are the clinical features? Lawrence-Moon syndrome has syndactyly, while Biedl-Bardet has polydactyly. And both of them have obesity, hypogonadism, intellectual disability, and retinitis pigmentosa. Drugs. Drugs can also cause obesity. Drugs like anti-epileptic drugs like valproate, lamotrigine, steroidal drugs will cause Cushingoid appearance, complication, metabolic complication. Obesity, increased adipose tissue, causes insulin resistance, metabolic syndrome, PCOS in women. Metabolic syndrome or syndrome X will cause PCOS in women. Metabolic complication, obesity, increased adipose tissue, insulin resistance, metabolic syndrome or syndrome X, and PCOS in women. Insulin resistance marker acanthosis nigricans. Insulin resistance. Hyperpigmented velvety patches on neck and axilla. Metabolic complications. Insulin resistance. What are the markers? Acanthosis nigricans. Hyperpigmented velvety patches on neck and axilla. Non-alcoholic fatty liver disease (NAFLD) leads to steatohepatitis, inflammatory changes in liver. If it's chronic, then becomes fibrosis. Management of obesity. Lifestyle changes, no response. Medical management, no response. Surgical management. Lifestyle changes. Sugar, avoid processed sugar, sweetened beverages, packaged foods. So, first of all, if you are obese, what lifestyle changes do you need? Sugars. Avoid processed sugar, sweetened beverages, packaged foods, fats. Avoid fats like trans fatty acids, saturated fatty acids. Increase intake of unsaturated fatty acids. Increase intake of vegetables, fruits, nuts, and grains. Decrease intake of salt, less than 5 gram per day. Increase physical activity, moderate to strenuous physical activity, more than 60 minutes per day, that is more than 30 minutes in school hours. Medical management. Treatment of endocrine disorders. Orlistat inhibits gastric and pancreatic lipase, decrease fat breakdown and absorption. Inhibits gastric and pancreatic lipase and decrease fat breakdown and absorption. GLP-1 analog, liraglutide, slows gastric emptying, decrease fat absorption. GLP-1 analog, liraglutide, shows gastric emptying and decrease fat absorption. Metformin indicated in known diabetes and women with PCOS. Surgical management, last resort. Laparoscopically adjustable gastric banding, LAGB. Capacity of stomach is decreased, decrease food intake, and this is your band. Laparoscopically adjustable gastric banding. In the next video, we'll see rickets and scurvy.